Bismillahirrahmanirrahim. So we want to start the acute stroke intervention session. So may I kindly request the chairpersons to come on the stage, please. So Wadi Janal Azhar Kiani, Dr. Nadeem Rizvi, Dr. Bashir Hanif, Dr. Umar Goktekin, Dr. Irfan Lutfi, if you could join us, please. Sir Tariq Ashraf, if you could give us the honor, sir. Dr. Farooq Jalisi, if you could join us, sir. So we want to start off with our first talk. The speaker is Dr. Hamza Ghauri from Rawalpindi Institute of Cardiology, and he's going to talk about posterior circulation. He's going to show us a case of posterior circulation stroke. Dr. Hamza, please.
Bismillahirrahmanirrahim. First of all, I would like to thank Pakistan Society of Interventional Cardiology for giving me this opportunity to be a part of this star-studded gathering, which is Pakistan Live 2022, and to represent my institute, that is Rawalpindi Institute of Cardiology, at this highly esteemed forum. So today, I'm going to present two cases of stroke intervention, and mostly it's basilar artery intervention that I'm going to touch. So I will start with first of my cases, which is the case of a 60-year-old lady who presented in our ER in a comatose state. Initial workup was done. Her blood sugar level was found to be 128 milligrams per deciliter. BP was 150/90. And after the initial workup, it was established that she was having posterior circulation stroke. So I'm just going to show you the next image, which is the CT angiogram of this patient. And you can see these are the two images that we have. And it's the distal basilar here, which is occluded. And you can see in both of these coronal and sagittal views. So with this, after the initial assessment, and since we had seen the view of the patient, after taking the consent, was taken to the cath lab. And we had seen in the imaging that it was the right vertebral artery which was dominant. So it was decided to have a brachial approach. 6 French sheath was taken. SIM2 catheter was used. And with this, the angiogram, which is a DSA imaging, which was done. And you can see this one here is a deep AP, also known as the Townes view. And this is the lateral view. And I think if you can clearly appreciate here that the distal basilar is occluded. So with this, we moved further and decided to go for the intervention, which is mechanical aspiration thrombectomy that was decided in this case. So we changed the sheath with a 65 centimeter destination sheath, which was taken up. The ostium of the right vertebral was engaged, and a Sophia Plus, which is the aspiration catheter, was taken up over a Chikai wire, which is 0.014 wire. So I'm going to show you the next image here, how we did that. So you can see this image. It's a slide video that you can see the wire is going up, and this is placed in the right PCA. This is the distal basilar, which is occluded, and Sophia Plus is taken up till this point, which is in the vertebral. But in this next image, you'll be able to see that Sophia Plus was taken distally, as distal as we could, and negative aspiration with a lock syringe, vac lock syringe was applied, and aspiration was done. Now, what happened was, I think something which we all look for while we are doing these interventions, that we were able to get first pass recanalization with sticky 3 flow. And this is what it is. So you can see that, and I'm also going to show you the comparison here. So you can see that it was well revascularized. The patient did extremely well. In the initial few hours, the patient started moving all 4 limbs. In the next few days, she was walking, talking, and she has kept a good follow-up with us. Now with this, I will move on to the next case. And all the cases are not that simple. This one was much more challenging and intriguing. So this is a 45-year-old gentleman who presented in the ER with quadriplegia, followed by loss of consciousness. Initial workup showed that his BSR was 256 milligrams per deciliter, BP 140/90. But interestingly, when we were doing the workup, we also found out that the patient was having inferior wall myocardial infarction. And most likely, this was the cause for him having a stroke. So we decided, after initial imaging, when posterior circulation stroke was established, that we'll shift the patient to the cath lab, we'll intervene for stroke first, and then the coronaries if needed. So you can see I've brought this regular anatomy, and in this case, we took a right femoral sheath, 6 French axis, and the left vertebral was engaged with a SIM2 catheter. So this is the normal anatomy. You can see both the vertebral arteries joining and forming the basilar, and then both the right-left PCAs, posterior cerebral arteries, are given. Here you can see the anatomy was slightly different. Vertebral arteries joining, and this is a tortuous basilar, and this is occluded distally. So with this, we proceeded. The whole inventory has been shown here, but I'm going to go through the case, and we'll explain it down the line. So the patient underwent a DAP technique for aspiration thrombectomy, as I've explained earlier, and this is the wire, this time being taken. It's the same Chikai wire, 0.014 wire, taken into the left PCA. And you can see the Sophia, which was taken up, negative pressure aspiration, and Sophia Plus was taken out. And we did the first run to no avail. We did another run, but still we were unable to achieve recanalization. So at this point, we thought of resorting to some other technique, and that was obviously Solumbra, which is the deployment of stent retriever, and this stent mostly is Solitaire X4 into 40 mm that we are using, and this was unsheathed in the left PCA by taking the Rebar microcatheter down. It was taken out, Sophia was taken up, and I think you can clearly appreciate here, and the whole apparatus was taken out. But unfortunately, after 2 runs of this, we were still unable to recanalize. And at this juncture, we had to think out of the box. So what did we do? We then moved to the next technique after these failed attempts, and this technique is known as the simultaneous stent deployment or a Y stent deployment. So you can see here, what we did was, we took the Sophia Plus out, we took 2 microcatheters, which were on a wire, took them up into the distal basilar artery here. So I'm going to make it easier for you in this still. Yes, so we took it up, parked both the microcatheters in both of these PCAs, and then they were unsheathed, and the stents were deployed after unsheathing the microcatheters. So this gave us a Y configuration. You can see these horizontal stumps. These are in the PCAs, and you have the vertical stump, which is extending. Both these stents have a vertical stump, which is extending into the distal basilar, and then the Sophia Plus was taken up. Ideally, it was supposed to be taken up, and luckily we were able to take it up almost up to the distal basilar, engulfing this vertical limb of the 2 stents. And after this, the whole assembly was pulled down. So this next slide, I think, is going to, again, this is not moving forward. So I think slides are not moving ahead. So what we did was we brought it down, and with this we were able to achieve Tiki 3 flow, and recanalization was done. If somebody, yes, I think now we have it running. So again, when you take it out, so I'll hurry on to this, this is the kind of formation you want. You have these 2 distal prongs hanging within the Sophia Plus, and negative suction is applied. And with this technique, you have the maximum aspiration, maximum clot capture, and this is exactly what we did. So I'm just going to show you the results, and this is pre-intervention, and that's post-intervention. And if I show you the stills, these are the still images that you can see, and you can clearly see the outcome. So the patient also underwent coronary PCI. POBA was done to the RCA with good results. Patient was then shifted out, and patient showed brilliant recovery. He was talking, walking, responding to commands in the next few hours. And I'm just going to show you this video. Obviously, this has been taken by the consent of the patient and by taking full permission, and he was walking, obeying commands. I apologize. I think this was somehow not coming straight in our initial run. So the patient was pretty much obeying all the commands, and he did very well. With this, I also would like to mention here that in our setup, we have almost done 26 basilar stroke interventions, and we have had a success rate of almost 70%. I think we'll have the audit coming very soon in the subsequent lectures. So with this, I would like to thank you all for your patient listening. Thank you.
Thank you, Dr. Hamza. So next, I'm going to invite Dr. Ömer Göktekin from Turkey, and he's going to talk about the need for stroke cardiologists and the training required for that.
Thank you, Dear Asim. I'd like to thank Pakistan Society of Interventional Cardiology for having me for this really important and big meeting. And we came here as a team from Turkey. We are 8 high-level interventional cardiologists in this meeting, and we are extremely honored and happy to be here. So, we have a huge problem regarding treatment of stroke intervention. In the US, for example, they have more than 800,000 stroke, and only 275,000 of them has large vessel occlusion, means can be treated by endovascular treatment, 1/3 of it, but only 3% of the patients are treated. So it's very low. You know, US is a very developed country. Why is that much low? Because there is no enough manpower to treat those patients. As you know, in the beginning, interventional neuroradiologists take care of these patients, but they are limited. They have limited number. They can't treat everyone. They can't work 24 hours in many centers because of the number in that institute. So some other professional group can help to treat these patients. And I think one of the important group are us. As interventional cardiologists, we can treat them. We have examples, we have very good examples, and result of interventional cardiologists is very similar to interventional neuroradiologists. That's why we are that's why Asim and others interested in this field. And it should be increased very fast. So we have role as cardiologists, we have role in stroke anyway, because we treat hypertension, we treat hyperlipidemia, we treat atrial fibrillation and PFO as a reason of stroke. And also, we have a role for carotid stenting. This is very important point. We have to treat carotid intervention before we start stroke intervention anyway. So I think the stroke intervention only for carotid interventionalists. If someone doesn't do carotid intervention, they cannot start stroke intervention right away. It's not possible. They have to start first carotid intervention. At least 25 cases should be done, and then later on, they can start stroke intervention. We have, I think, enough catheter and wire cycles. We have very similar device in coronaries, similar macrocatheter, similar wires even. So we have good mindset for that. We can work 24 hours. We can go to hospital at the middle of night. Very few neuroradiologists goes to hospital midnight, but we go every day. And also, in many, which is good advantage for us, we have many good relation with the stroke neurologists in our hospitals. We have already have a strong link because we have common patients. They send their patients to us. We send our patients to them. So we have a good relation with stroke neurologists. I think this is a very good base to start stroke intervention. As I told you, we have to start with the carotid intervention in many countries. For example, in my country too, now we are leading coronary artery stenting. We do much more than interventional radiologists for coronary artery stenting. So in that case, if we do routine coronary artery stenting, why don't we do acute stroke intervention? Of course, if we have enough training and knowledge. That's the question. Anatomy is very important, but it's not that big deal. We are cardiologists, we are, have enough, I think, IQ to learn neuroanatomy. I think easily we can learn it, but we have to know everything about it. So, for carotid for acute stroke intervention, one of the most important part to deal with the arcus aorta. It's important. We have type 1, type 2, and type 3. Type 3 is difficult to engage and access, of course, and especially in the elderly patients, there are lots of atheroma. easily we can have another embolization when we try to access the carotid artery. So that's why we have to do this skill. We have to have the skill before starting stroke intervention. We have lots of catheter to reach to access the carotid artery, and also for vertebral arteries. So those some catheters for complex arcus aorta. If it is type 1, we can deal with the right Judkins or vertebral artery. Or if it is type 3, most probably we need Simon catheters, but we have to be careful when we reforming them in the aorta. So, for example, this one is type 1 and type 2 and type 3, and we might have a big problem if we have type 3, especially in very elderly patients, like this, for example. If we can't engage in 20 minutes, so we had better stop it, because we might have thrombotic event, embolic event. So essential components of endovascular therapy, patient selection. This is extremely important, of course, but I think this part is mostly should be done in our stroke neurologist. In our experience, in our hospital, stroke neurologists choose the patients and they ask to operate the patient from us. So I think patient selection, of course, can be done by cardiologists if they have enough training, if they have, you know, proper fellowship program, like 1 year or 2 years. Of course, they also can select the patients. Appropriate team members is very important. We should have good radiologist, good stroke physician, good neurologist, and interventionalist in that team. We don't need to have mostly anesthesiologists because we don't do general anesthesia. Studies shows that if we do general anesthesia, results are worse than local sedation. We have to identify the site of occlusion. This is very important. It's not like coronary. Sometimes you look for very carefully. Sometimes easily you miss. You can you may not see it. Stable access is important, as I told you. Pharmacological selection is important because we like heparin in our procedure, but this could be very dangerous in stroke intervention. We have to be very careful about this. And equipment selection is important. We have to select accordingly. Respect the artery. I think this is very important. Arteries are different than coronaries. We should know when we stop, right? So the aim is not to open the artery here. The aim is to help the patients. You can have the open artery at the end, but you have nothing. And post-op care is important, and again, stroke neurologists will do it. Intracerebral hemorrhage is one of the most important issue and is wolf nipping at our heels. Patients easily bleed. We can have easily big intracerebral hematoma. We have to be very careful. You know, if we have score is high, we have more hemorrhage. If the duration of ischemia is longer, we have again more hemorrhage. Size of infection is important. Size of penumbra is important. Blood pressure, blood glucose, patient age, pharmacological therapy, collaterals, dementia, device, and choice of anesthesia is also important regarding hemorrhage. So we should afraid hemorrhage. Identifying locations of occlusion is important. We have to have excellent angiography technique for that. We have to have multiple angles, STIP AP, true lateral, large field of view imaging, entire skull and scalp. Delayed filming is important. Sometimes we see, you know, the occlusion at the very end of the fluoro. Cortical blush, vessel cut off, early venous shunting, retrograde filling, clinical correlation. For example, if you look this patient, I don't know, as cardiologists, any of you can tell me where is the stump, where is the occlusion? You know, this AP and lateral, but it's not that clear. There is occlusion here. If you look that lateral side, there is, you know, no vessel here. It must be vessel. There must be vessel there. So there's occlusion, but where is the occlusion? If we go a little oblique, we can see better, but there is occlusion here. So this is one of the important parts for us as a cardiologist, but as for everyone, you know, who does this job, also for neuroradiologists, we have to look very carefully, and we have to see all vessels. Stable access is very important. You know, we can use, normally now we use routinely 8 French balloon guiding catheter. Studies shows that it's more beneficial, you know, to using 8 French, balloon guided balloon guide. Rarely sheath income carotid for extra and proximal tortuosity. We have to, sometimes we may have to go more distal. Distal access catheter instead of proximal distal tortuosity is important, and these days mostly we use, as Hamza showed, we use distal access catheter like Sophia. They help us a lot to go more distal and to do aspiration. Pharmacology is very important, as I have told. Heparin, we have to be very gentle regarding heparin. We give heparin why? To prevent catheter clotting, okay? So to do that also, we should give continuous fluid through our catheters. We may need thrombolytics, and also we may need GP2B and 3A inhibitors. So most of the time we use 6 to 8 French sheath, and routinely we use now neuroguide catheter like Sophia. Balloon guiding is very helpful. We have Mercy, Cello, and the others. And regarding wires, in some centers, I don't know how you do, ask him here, but sometimes not easy to reach. You know, neurological wires, not easy. Yeah. In that case, we can use some coronary wires, some coronary hydrophilic, soft hydrophilic wires like Fielder or Whisper low sport catheter. But if you have neurological one, of course, those could be better. And microcatheter is important. They are a little bigger than our microcatheter in terms of lumen. We have maximum, Trevo, rapid transit, etc. This is balloon guiding. After place the guiding, we inflate the balloon like MoMA, very similar to MoMA. So, you know, we used to use MoMA, the MoMA catheter, so it's exactly the same. I think Asim will talk about more stent reaver devices. They are like stent-like device to the embolectomy. We have solitary retrieval and other many devices now in the market. And there is a penumbra aspiration system. We can do aspiration by manually, but also we can do aspiration with penumbra device. And we have also other techniques, like Hamza mentioned, we have Sonimbra, adapt or push and pull technique. Respect the artery is extremely important because there is no external elastic lamina. There is a minimal adventitia. They are the brain artery is very gentle, easily we can perforate them. Thin tunica media and muscularis. And also we have macroscopic perforators. We don't see them. They're very small, but if we occlude them, we might have a severe result. So we had better use no-touch technique. Never oversize. It's not like coronary. Better to be undersized. We have to use soft equipment. I have maybe another minute, or we finished it. Maybe 1 minute more, if you give up. Yeah. So when we stop, you know, after 1 hour, if we don't do anything, we had better stop. After 2 hours, we should definitely stop. If we try more than 2 devices, we had better stop. If the patient has clinical deterioration, we should stop. If we have pool collaterals, we should stop. You know, if we have wire perforation, reperfusion injury, distal embolization, if we have big initial infarct size, we should stop earlier. We might have some complication like spasm, dissection, perforation, hemorrhage, and failure. And also we might have reperfusion intracerebral hemorrhage and cerebral edema after the procedure. If we have perforation, we have to tamponate by balloon. You know, we shouldn't oversize balloon again. We have to reverse all anticoagulations. We have to have lower blood pressure, less than 100, and leave the vessel occluded because we have done enough. It's better to leave it occluded, and we should call the neurosurgeons, but they don't have that much to do. Post-op care, mostly in our institute, is done by neurologists. They take care of the patients. And to start stroke intervention, we need to have very good stroke neurologists, and we have to have very good relation with them. Without neurology help, we do nothing. Because they have the patients. They send their patients to us. So this is the summary. We have to select patients appropriately. Small nettic core, for example, large ischemic penumbra. We shouldn't overdose pharmacological agents. We should know cerebral anatomy, and we should see where is the occlusion and if there is any tandem lesions. Use the softest and latest aggressive device for the job. Don't put the patient's GA. It's better to do it local sedation, under local sedation, and we should know when we stop. Thank you very much for your attention.
Thank you very much, Dr. Omar. So I think the most burning question is, in Pakistan, do we really need cardiologists to come into this field and learn and start stroke intervention? Is it really doable in a cardiac center? So I think let's hear what our panel of experts has to say. So can I start with General Kiani, please? So what are your views on this? And then Dr. Nadeem Rizvi and others can join in as well.
Thank you. I think most of us, they are very trained cardiologists, and as far as the skills are concerned, you're very familiar with the disposable devices, all kind of devices. And you know, I think, when to stop and where to stop. The thing is, the kind of experience a cardiologist have, I don't think a neurologist, his experience with such kind of a volume. And it usually takes, the learning curve is very small as far as the cardiologists are concerned. I think we had the similar kind of apprehension when we started this program in Rawalpindi Institute of Cardiology. And there was a lot of anxiety and then a lot of opposition when we started this program, because I think it's not initially we thought it's not a cardiologist's domain, but someone has to do it. And the people were suffering. And since we have so much of coronary load on our side, it's very difficult to handle that load, but I think you have to, someone has to do it. We were waiting for the neurologist, interventional neurologist to come in and they play their part. But I think this is really very important, and we've done wonders. You have a proper kind of a training and how to select the patient, how to triage the patient, how to manage the patient. Then you have a multidisciplinary team on your side. That's a very important thing. You should have a neurologist on your side, you should have a neurosurgeon on your side, then intensive care. I think intensive care after the procedure when it's needed, especially after the procedure, you have a hemorrhage or cerebral edema and you need intensive care of neurology, then you should have a support of your colleagues. That's a very important thing. And we were very lucky that we had a very forthcoming team in Rawalpindi available. We have people from DHQ, neurosurgeons, anesthetists, then physiotherapists, everyone was available. And then we have a very young guy who was as a budding neurologist. He was with us in the team right at this site in the RIC, and they've done wonders. Can you imagine? I think they will later in the presentation, they will give the data, how many cases, more than 300 cases, 400 cases they have done over there. Anyone in the neurological center done that number of cases or not? Anyone has crossed a figure of 50 at all not. I think this is how to do it. This is how to, I think the cardiology institutes in Pakistan, be it our RIC, then it's AFIC, or PIC, or FIC, or Multan Cardio Institute, NICVD. I'll leave the Wazirabad Institute of Cardiology because they don't have a required multidisciplinary support in that area available. But all other institutes, they can start this program with it. We have got the required disposable available with you, the requirement, I think, desired kind of a training, and then you have got I think it's a wonderful, a very forthcoming, dynamic Asam, who has, I think, he has offered himself and then volunteered to train all the people who are interested in doing the intervention and acute stroke program. And when I was entering this hall, then I met a few of the young interventional cardiologists from NICVD, and I was pleasantly surprised to know that they have done more than 40 thrombectomies in NICVD. And I think kudos to NICVD and their leadership over there. And this is how I think you have to engage, involve yourself. And this is really very important. We know that there's a coronary workload, but then the certain dedicated interventional cardiologists, I can take this task of acute stroke intervention and start this program. So it's not difficult at all, I think. If you've got a will to do it, you can do it. And it's doable. It's not, you can say this not do, it's doable. Once our neurologist colleagues and interventionalists, they come up to the mark and start doing this kind of procedure and take this load off, yes, then I can say, okay, thank you, my goodbye, take all the acute stroke intervention cases over there, and then you can, I think, concentrate on the cardiology, but focus on cardiology. But this is what it is, I think, is doable. And the cardiologists, I think, they normally feel very comfortable doing these procedures because very familiar with the tactile feelings of the catheters, of the wires, of the balloons, of the stents. And if everything goes wrong, complication, whether it's a dissection or perforation or no flow, they know how to manage it. They manage the coronaries. I think very difficult to manage the coronaries, but they can manage this cerebral circulation.
Sir, thank you very much. Before I request Dr. Nadeem Rizvi to respond, may I ask Dr. Omar, so Turkey is very well advanced in the field of medicine, and I'm sure interventional neurology and interventional radiology would also be quite adequately established. So as an interventional cardiologist, you do so much stuff from interventional cardiology and structural heart disease and CTOs. What made you come to stroke intervention? You're doing stroke interventions in Turkey, so how did you land up here, and what's the state of cardiologists getting involved with stroke in Turkey?
Yeah, first of all, we do extensive carotid intervention. So I think in our mindset was ready to go up, first of all. So we do, for years we do carotid intervention. Secondly, after we are not in the first cardiologist who does this. I mean, for many years, some colleague from US, some colleague from South Africa, for many they do stroke intervention. So after seeing them, and after seeing that the procedure itself is not that difficult for us because we are very familiar to use microcatheter. We know all kind of microcatheter. We started CTO business with the Echelon 10, for example, which belongs to neurology. In that time, we don't have. Some 20 years ago, for example, we didn't have enough microcatheter. We used their microcatheter for many years. And then after I see that we can do it and there is unmet need, so I said we had better go involved.
So even in Turkey, you think there's an unmet need for stroke interventionists?
Sorry?
So in Turkey also, you think there's an unmet need because of
everywhere.
You decided
Yes,
to
no
come
need to say it in everywhere.
So just to add on to that, not only Turkey, but cardiologists are involved in stroke intervention in USA, in Germany, Netherlands, Portugal, Slovakia, in South Africa. So there are many countries where interventional cardiologists are actually part of the stroke intervention team and they do the interventional aspect. So Dr. Nadeem Rizvi, your views on this? You are current president PSIC, so your views do matter because a lot of people have this fear in their mind that the society needs to be behind them before cardiology jumps into this.
No, I think, I mean, my views are well known, and they're pretty radical. They've always been, because Pakistan is a specific environment. And you cannot really superimpose a Western or a US or a European model straight away here. People die here. It's a matter of, you need to have two, three things which are essentially red lines. You need to keep the patient safety first. MBBS gives you the license to treat patients. Now, the further super specializations have to be modeled according to your local environment. So just to give you a small, and everyone knows this, when we started the NICVD primary program, the first angioplasty, the first case that was done in Larkana of catheterization was an acute anterior MI. There was no angiogram before that. There were no surgical backup within 300 miles. And even if you go in the desert in Mitti, there are hardly any blood labs, but people get MIs. How are they going to travel 4 hours and things? So we set up so in the whole of Sindh, NICVD does primary angioplasties without backups, with safety, which is equivalent anywhere in the world. Because if you are having an MI, it's an acute emergency. If you break your bone, you're not going to wait for an orthopedic surgeon, or if you have a bullet wound and you bleed to death, someone has to. So I think it's an unmet need which you and with Dr. Azhar Kiani, I think the thing was that essentially, if you allow me to be a bit blunt, he bulldozed it, and despite all the resistance that you had. So it's a matter of domains that we have, it's a matter of egos, and I think those have to be transcended for our local environment. So I am 100% behind anyone who gives a 24-hour service which is according to certain standards. So standard care has to be maintained. It doesn't matter whether it's a neurologist or a radiologist or a cardiologist. The standards are set up by international data, safety regulations. You fulfill that. Whether you are a neurologist or a radiologist or a cardiologist, that doesn't matter. As long as you fulfill the basic criteria. And 24-hour services, there are only available in cardiac institutes in Pakistan, fortunately or unfortunately. There are no 24-hour neurology institutes. There are no 24-hour radiology institutes. There are only 24-hour primary services given by tertiary cardiac centers, which are all over the country. So how can you not give you, if a person ends up with stroke, if a patient ends up with an MI, he has a renal dysfunction. So would the nephrologist say that I'm not going to go and see the patient because it's in a cardiac institute? No, he comes there. You have dialysis, you have infective control people. So similarly, so I think the egos have to be set aside, and the society will 100% back up this stroke program, and I think it should be done in every cardiac institute in Pakistan.
Thank you, sir. So any question from the audience? It's a good opportunity to ask any question regarding the role of cardiologists. This is the topic. So anybody interested?
I think the radiologist is here. Let's get his view, because I'm sure he's doing acute intervention in a cardiac center, so his colleagues must be on his back. Let's see what Dr. Irfan
Let me
Lutfi.
introduce Dr. Irfan Lutfi. He's leading the program of stroke intervention in NICVD. He's an interventional radiologist. So let's see what his views are.
I think it's a time to need to start mechanical thrombectomy in every center, because when I start doing neurointervention, there's only one neurointerventionist who's doing neurointervention in Karachi, and he's not trying to teach any other person. So I thought at that time, why only one person? Because a lot of disease of neuro, and only one person is treating, and he knows how to treat ischemic stroke. So I start doing peripheral and neurointervention, and then a lot of people of my society, other societies, start to trying to stop me for doing this. Then I go outside, you know better than any other person. So when I came here back to Karachi, and I start these services in Ziauddin Hospital, But unfortunately, this mechanical thrombectomy or ischemic stroke services is not the domain of the private sectors. It's only doable in the public sector. This is my personal opinion, because if patient is landed at 3 a.m. or 5 a.m. And you ask to uh, submit the 5 lakh or 10 lakh rupees, how can it possible? Anybody can draw the money of 5 or 10 lakh rupees from his pocket. So it's not doable in private sectors, my point of view. I tried 2 years in private sector, then I joined NICVD, and I'm very happy to join NICVD, and there's a lot of burden of ischemic stroke in our population.
I
Because
think you've raised a very important point here. And since Dr. Bashir and is from a private sector,
yes, yeah.
and they've started doing stroke intervention as well, so I would like the private sector to respond to that. How are they managing the stroke interventions?
Okay, so I think first of all, what Nadeem or Dr. Kiani has said, I fully agree and echo that. I think if we had enough an interventional neurologist or interventional radiologist, then it's probably okay, they could have done it, but cardiologists, since obviously they are doing coronary interventions, they can do it. But just one word of caution, I think you will probably agree to that we need to have some basic training. It's not exactly same as coronaries. So you need to understand the basic things about brain before you start doing it. And you are doing a marvelous job, no doubt about that, about basics of that. And I think there is a little bit more into it. Somebody need to go, and you are offering now people to come to you and see while doing it. Just theoretical knowledge may not be enough. So it's very important that those who are interested, they need to really read about it, learn basics, and maybe see and do some cases and then start doing it. So that's very important. Now regarding private sector, you asked, I think Irfan is absolutely right. It's not easy. It's very costly and very difficult. Luckily again, although Tabba Heart Institute is private, but it's a not-for-profit, and we have the luxury of a lot of funding available. Just like we did for acute myocardial infarction, although it's a private hospital, I think we are the only private hospital. Anyone coming with acute MI, they will be taken to the cath lab for a primary PCI, doesn't matter even if they don't have penny. And that is like we started about 4 or 5 years ago. Before that, just like other private hospitals, we used to ask for money and all that kind of stuff, but I push for it that this is the place where we really make a difference and we have to do something. And I asked Tabba family to give us funds that we should be able to do the primary PCI, and those patients later who can pay, they can pay, otherwise they will be given from that welfare fund. Similarly, we have started the program, and we also have been discussing with family, and they had supported us, just like they supported us to start the TAVI program, they have supported us to start the stroke program also. So now again, I personally feel that I think the difference we make by doing stroke intervention is much more than with acute MI even, because it's a disability which is going to be for lifelong for the patient and the family. And if Abdul Salam showed some cases how you could, if this would not have been done, those patients would have been like disabled for life. So it really makes a huge difference, and I think there's no doubt about that all the government institutes definitely should try to work on it, and private institutes also should start wherever they can help those patients. If not, anyone coming to them, they can refer to the places where it's being done.
And it's important, even if you can't start the service, you need to learn the skill, because you have complications like stroke during your coronary interventions. You should be able to retrieve your patient yourself. So moving on with the program, I'm going to invite Dr. Kamran from NICVD, and he's going to share his cases of anterior circulation stroke and maybe some NICVD data as well.
While you are waiting, I'd just like to ask Dr. Irfan Lutfi, the Society of Interventional Radiologists, what's their point of view? Why don't they meet with the Society of Interventional Cardiology and Neurology and get a training program of sort of which is agreeable to everyone? Don't you have meetings like these?
We have a meeting like this, but they try to come, any neurointervention try to come with the proper channel, proper training and all that. And all the time when I visited RIC for many time, I face a lot of resistance from my society. So why you are going to train the cardiologist for neuro or stroke? So I can't.
So is that the
From my
same,
side.
Umar Gotkin, is that the same in Turkey? Is there some resistance between neurologist, radiologist and cardiologist, or?
Yeah, we have, yes, we have resistance between cardiologist and interventional neuroradiologist, you know, a strong one. But we have very good relations with interventional neurologist. So in Turkey, interventional neurologist and interventional cardiologist work together. This is, I think, our success is here.
Yeah, I think in Pakistan, although we don't have, there's probably only one interventional neurologist, but even general neurologists have a lot of resistance. And we try to talk to actually the neuro societies, and actually the neuro society president was my friend, and I tried to convince him that we need to work together. And he was so against it that he flatly refused. He said there's no way that a cardiologist should be doing this, we'll do whatever we do and that kind of stuff. So it's unfortunate, but that's how it is.
So I think we should start a fellowship in
Are the other
stroke intervention.
interventional radiologists doing stroke intervention in Pakistan or in Karachi? Do you know, Irfan?
I think,
Stroke intervention.
sorry.
Any interventional radiologist in Karachi or anywhere else?
A well-trained of ischemic stroke intervention, otherwise there's no one.
So, means the RIC, the NICVD, and TABA. I think the three institutes are doing stroke intervention most commonly.
And
I think,
I
you
think
know-
we have to sit together and start train many people, because the burden in the society is too much burden in the society. When I joined in ICVT, then I realized there's a lot of patients with ischemic stroke, more than any Western countries, any European countries, because ICAT is very common in our countries like India and Pakistan. So there's more strokes. Even 30 years of age, 40 years of age, you have a stroke every other day.
I think we should have a terminology like primary stroke intervention, like primary PCI.
Yes, but I think, I think, to be honest with you, this job for many years will belong to interventional neurologists, because they have the patients, and if they know how to do it, they will do it for sure. And how we convince them, you know, Bashir, we saying that we are here to help you, to teach you how to access the groin, you know, how to go to carotid. So we try to teach them carotid stenting and other things, so we work together. And I believe that some 30 years later, they will do it, because it's a huge, you know, work to do. To me, much more important than primary PCI. We are talking about, you know, something very different. So they will do it. Maybe 20 years later, 30 years later, we will not involve anymore, because neurology is big, you know, specialty. Yes, so they have tons of specialists everywhere.
That's what I actually offered them. I met the president and secretary of the Neuro Society, and I told them that we will help you to train you, and till you get trained, then you can do it. But still, there's only one interventional neurologist, and he's like dead against that anyone else should be doing it, and there's like very difficult. But I guess
Then
over
it
here it
takes-
doesn't really matter, because we are doing it
If
anyways.
they do this, it takes maybe 50 years
Yeah,
to be routine
exactly.
practice.
Yes, please. Mike.
So I'm glad that military has started it. So they've got their neurologists doing it. They've got Afiri, where the radiology has also started doing it. And I'm not sure about neurosurgery. Somebody told me that they've got a cath lab in CMH, and somebody from them has also started doing it. So, although it would have been better if they combined their efforts, but still they're doing it separately, but at least they've started. So that's the good thing.
Just to add to these comments, in UK that radiologists get trained in neuro stroke management, and at most of the hospitals, acute stroke patients are similarly taken to for CT scan and MRI, and whatever is required is offered by the radiologist. So I think that is the domain of the radiologist, interventional radiologist in developed countries, but obviously there is always an overlap in developing countries. So let's see, whoever starts doing it, as long as it's being done by a trained person, as Dr. Bashir Hanif has said, that doing a procedure is not enough. Knowing about it, how to do it, and what are the consequences, and where it is going to lead to it, and what would be the complication, that should be known. Because as a cardiologist, we are aware of all the complications of the coronary interventions, so it's not difficult to manage the coronary interventions.
Thank you. Thank you very much.
Can I
First of
just
all, I would
ask
like
a-
to thank you, the honorable panel, and the Pakistan Society of Cardiology Intervention for giving me the opportunity of representing the NICVD, my institute, for the platform of the stroke intervention, which is right now the growing and flourishing from the stroke intervention standpoint. So my topic of presentation is the MCA intervention. So I would like, first of all, just very brief, quick view about that. Majority of the stroke has already been said by the Dr. Umar that they are the ischemic one. And out of this ischemic stroke, almost majority of them are because of the large vessel occlusion. So he's already explained well to us. So just briefly, what is mechanical thrombectomy? So that's the removal of clot, and if it is done with the stent, with the help of the stent retriever, that is called as Solumbra technique. And if it is done without the use of the stent retriever, that is called as EDAP, a direct aspiration first pass technique. So that's my case. So I'm going to present this lady who was a 70-year-old lady with a history of hypertension, function class 2 to 3, and has had permanent pacemaker implantation. And she presented with left-sided hemiparesis. Her initial clinical evaluation in the ER showed left-sided hemiparesis, left facial drooping, right gaze preference, dysarthria, and her NIH score was calculated to be 16. So initial ER assessment was completed within 20 minutes, and this is our initial form. And this video was made on the presentation with the permission of the caretakers and the authorities. So here we can appreciate that she was unable to move her left leg and left arm, and there was gaze preference on the right side and left-sided facial drooping. So that was the initial presentation. So within the next 15 minutes, she was taken for the non-contrast CT, and that ruled out the bleed, and her aspect score was turned out to be 10. So within the next 15 minutes, her contrast CT was performed, and here we noted that there was occlusion, there was a cutoff in the right MCA, middle cerebral artery. So we can appreciate in both views. So we reviewed the selection criteria for thrombectomy for her, and these were the points as far as the age, pre-stroke, MRS, NIH. So she was completely fulfilling the criteria, and then in the next 10 minutes she was shifted to the cath lab because it was very close to the CT angio unit. So this is her diagnostic cerebral angiogram. So here we can see the cutoff in the M1 segment of the right middle cerebral artery. So for the mechanical thrombectomy, we build up the tower, and that is consisting of the, first of all, the guiding catheter, then the dyslaxis catheter or the intermediate catheter, microcatheter, and the wire. And here we can appreciate. And finally, we perform the Solumbra technique. So we extracted the thrombus with the help of the stent retriever. Post-thrombectomy results are this. So this is the oblique view. So we can see the occluded artery has opened now, and that other one is the lateral view. So here we can appreciate what was the pre and what was the post for her. So that was a clot which we retrieved with the Salmura. And this was, the video was made immediately post-thrombectomy, like within half an hour or so. So where we can appreciate that she was able to move her left arm, and her gaze was actually normalizing immediately. And that was the next day thrombectomy. Here we can appreciate. I think there was sound was also there. So she was nicely vocalizing, verbalizing, understanding the command, and moving her both her upper and the lower limbs. And that was the next day CT that we performed, and it turned out to be very satisfactory. Then there's another case, just a quick view of that. So on the left-hand side, we can see the baseline presentation in the ER, and that was presented with global aphasia, and he was unable to move his left arm and left leg. And that was the presentation in the cerebral angio. So left MCA was occluded, and then we performed the thrombectomy again with the help of the Salmura technique. And this is the post that we can appreciate over here. And a few more stroke intervention clips that we performed at NICVD. So again, MCA, which is opened nicely. Another one, again MCA, again MCA. And the last one that we did out of like over 40 cases, the posterior circulation one. I would like to give an overview how we selected the criteria. As Professor Kiani has already, told us where there's a will, there's a way. So actually we were followed that pathway. So initially, in total, we entertained and evaluated almost 800 patients in NICVD ER, and 200 were straight away referred to the Jinnah Post-Medical Center because they were not fitting based on their history and the initial evaluation for the thrombectomy criteria that I already explained. And out of these, only 500 patients were left and selected for the screening through plain CT scan. Out of those, 345 patients showed ischemic stroke and 155 hemorrhagic stroke. Out of those 345 patients, 195 patients were excluded based on their aspect score, and then we were left only with 149 patients. And subsequently, they underwent the contrast CT scan. Out of those 105 patients turned out to have small vessel occlusion. For that, we just need the medical treatment and follow-up, and they were transferred to the JPMC again. And then finally, we were left with 44 patients who have shown the large vessel occlusion. Out of those, 5 patients were excluded because they were because of the consent issue or the other exclusion criteria. And finally, we were left with 40 patients in which we performed, and they qualified for the mechanical thrombectomy. And TPA was used only in 9 patients according to the guidelines. So as far as our stroke intervention program is concerned, so I would first like to mention about Professor Nadeem Kamar, who, and the main credit goes to him, who is actually thought about it, and with the view that cardiac interventionists can perform because of the, long interventional skills of from the cardiology aspect, and his vision was to provide the 24/7 stroke intervention program, and that should be free of cost all over the area. And then I must pay thanks for the continuous motivation from Dr. Asim and Professor Tahir Kadir, who actually helped us in setting up the program from the ER to the cath lab. So he facilitated that. And finally, Professor Irfan Lutfi, who actually headed our stroke intervention program and is sitting with us. And lastly but not leastly, for their continuous technical and the moral support, our fellows from the USA, Dr. Syed Fazal Zadi, who is a stroke interventionist, and Dr. Hisham Salahuddin, so who continuously, involved in our technical support. And this is our right now team of the NICVD, myself, Professor Irfan Lutfi, Salman is a neurologist, Jahangir Ali Shah is sitting in front of me, Dr. Khalid, Dr. Rajesh. Thank you.
So next we're going to talk about what are the techniques for doing this mechanical thrombectomy. So I totally agree with the training aspect. There is no shortcut, but this is also true that for the interventional cardiologists who are experienced enough, it's not something too difficult to learn. You're already doing CTOs, you're handling microcatheters, and you're taking out thrombus from beating heart, moving arteries, moving targets. So removing the same thrombus from static arteries. So probably that should not be very difficult, provided we are willing to sacrifice a bit of our time and we have the motivation to deliver this service, then yes, we can learn it. Can I have my slides on, please? So mechanical thrombectomy, we've seen the eligibility criteria and also I'll just move on with the, okay, good, I have my slides now. So different techniques available to us, keeping it very simple. One way is you just aspirate the clot. You go in, just do the aspiration and bring the clot out. The second technique is stent retriever. So here, the difference from the coronary is that in coronary, we mostly have an underlying stenosis as well. There's a thrombus and there's a stenosis in primary PCI. So we have to remove the thrombus and we have to deliver a stent there. But in majority of the stroke patients, there is no underlying stenosis. We have 10 to 15% cases where we have an underlying stenosis as well. But in majority of the cases, it's just the thrombus that needs to come out. So the stent that we use here is not permanently deployed. This is the stent that goes in, it grabs the clot, and we bring the stent out, so we leave nothing behind. So this is the second technique. The third technique, of course, would be if we combine the two techniques. We do the aspiration and we use the stent. So that's the third technique. So going over the first technique, this is called ADAPT, which has been shown previously in the different cases. So what you see here is you have a guide catheter sitting in the internal carotid artery. So it's not common carotid. We make sure that our guide catheter sits in the internal carotid artery. Then we've got the wire, which is an 014 wire, which leads into the middle cerebral artery or wherever we need to go. It is supported by a microcatheter, and just behind that is an aspiration catheter. So we have four things going forward. One is your guide catheter, through that is going your aspiration catheter, which is mostly 6 French or 5 French, and then you've got a microcatheter and wire leading the way. So you just take your wire and microcatheter across the clot, and then you bring in your aspiration device, you remove the wire and the microcatheter, and you put suction on the aspiration catheter, and you pull the clot out. So this is a patient of ours with basilar occlusion, and you can see that the distal tip of the basilar artery is occluded, and we know that the distal basilar tips are mostly embolic occlusions. So what I've shown in the cartoon is there's an orange clot sitting there, and the aspiration catheter goes. The moment it hugs the clot, we stop there, we start aspirating, and we just bring everything out. So this is exactly what was done here. So that you can see an 014 wire, which had initially gone up with a microcatheter, and then the aspiration catheter has come right up to the tip of the distal basilar, and then the wire and microcatheter have been removed, and suction applied to this aspiration catheter, and aspiration catheter is removed. So that's all that has been done, and the basilar artery is all open. Now this basilar artery has a mortality of 95 to 97% if not intervened. These patients either will be quadriplegic or they will remain comatose. So aspiration, it was I think maybe 20 minutes job, and the patient is back to normal life. So this is very effective if the clot and the catheter are coaxial to each other. But if the clot and the aspiration catheter are not coaxial to each other, and you have the scenario that is shown on the top figure, then it's not easy to aspirate this clot. So in this situation, we need to do something different, and this is where the stent retriever will be of help. So in this case, you can take a wire, take a microcatheter, just go across the clot, remove your wire, and through the same microcatheter, we push our stent retriever in and deploy it across the clot, like this. So in this case, we haven't brought any aspiration catheter up. It's just the microcatheter and the stent that has been delivered. And then we just pull it out, and it brings the clot with it. This is the second technique. And this is a case which shows the same thing. We've got a pseudo-occlusion of the carotid in this case, and we've got an MCA occlusion. We did aspiration from the carotid, and we opened up the whole carotid. And then we saw that the MCA is also occluded, so you can see a wire with a loop going in front and a microcatheter behind it. And then this stent retriever is being deployed. We actually unsheath the stent. We bring it through the microcatheter, and then we just keep it there, and we pull the microcatheter back. The stent automatically gets deployed. So we unsheath the stent there. And after that, we just removed the stent, and you can see the clot that came out with it, and you can see the recanalized middle cerebral artery. So this was the second technique. But our main aim is to get TK3 flow in the very first pass. So how do you make sure that you get TK3 flow in the first pass and you do not get distal embolizations to new territories? So the best way of doing it is by combining the two techniques. So when you combine these two techniques, we call it a Sulumbra technique. So what we do is, once we've deployed the stent retriever, instead of pulling it out, we also bring in our aspiration catheter. So the aspiration catheter comes right up to the clot, so we apply suction through it. So now we've got the clot grabbed in the stent, and we're also applying suction, so we pull both the things out together, and this is called Sulumbra. So this is an interesting patient, 45 years old, young lady with severe mitral stenosis, mitral regurgitation, came in with 2 hours history of stroke, left-sided hemiplegia. Interestingly, as part of the workup, we do the ECG as well, and that showed an anterior STEMI. And she also had acute limb ischemia, so she had showers of thrombus everywhere. So you can see that there's no flow in the right femoral at all. There's no flow. You can see the sheath is blocking everything. So we took the patient to the cath lab. Whenever you have this situation, you always start off with the brain first. So you can see a stent deployed here. And then we brought the aspiration catheter up. You can see the aspiration catheter going up. The stent is already deployed there. And once the two are together, we simply pull both of them together out, and we recanalize the artery, and we quickly moved on with the primary PCI. We can see the LED blocked here, and we knew that this was embolic. She's very young. We tried with the thrombustor, it did not work. We are lucky that at RIC, General Kiani provided us with this angiojet machine. So we used the angiojet catheter to aspirate this clot because it was a big embolus which thrombustor could not. And you can see the final result after that. And then we had our cardiac surgeons stand by in the cath lab, and right there and then they performed the Fogarty embolectomy, and the acute limb ischemia was treated. So all three things could be managed in the cath lab. And occasionally, Dr. Hamza has shown this technique being applied on the basilar artery as well. We have to apply, if the Sulumbra technique fails, then we can use 2 parallel stents, deploy it in 2 branches, have the aspiration catheter behind them, and then pull everything out. And usually it succeeds. So this is where nothing else is working. So this is a patient of ours with a ICA terminus occlusion. And you can see on the other side, there's a stent retriever and a catheter there. And we did Sulumbra for this, but they did not succeed. We tried twice or thrice. And then we decided to go with the 2 parallel stent technique. So we deployed 1 stent in the anterior cerebral artery, the other one in the middle cerebral artery. And once the 2 stents were deployed, then we brought our aspiration catheter up, and amongst the 3 of them, when we pulled it out, we were able to remove that thrombus, which otherwise we were not successful in doing. Occasionally, you have difficulty going from the femoral approach. You can go to brachial approach. But at times, even the brachial approach is not possible because of the carotid tortuosity, and you can't take any hardware up. So in those situations, you can do a direct carotid puncture as well. So This is a patient who was our father of our cath nurse who came in with stroke, and unfortunately, femoral, brachial, every approach, we could not take the hardware up. So we gave the patient general anesthesia, we put the patient on ventilator, we took a micropuncture kit, we took a roadmap. You can use the ultrasound guidance or you can use the roadmap to do the direct carotid puncture. And we did it with the micropuncture kit. And then you take a check injection to make sure that you're in the internal carotid artery. But the puncture has to be in the common carotid as low as possible. And then we took our 6 French sheath in, and then rest of the procedure was simple. We didn't have to do much over here. What is important in this is that whenever you have to do a direct carotid access, it's important that you intubate the patient now, because if you cause any carotid hematoma, intubation may become very difficult later on. So it's much safer to intubate the patient and then do the direct carotid access and do the puncture. So with that, I think I'm available for any questions that you have regarding the thrombectomy techniques. So please feel free to ask any questions. Sir. So distal embolization is, yes, it does happen during stroke intervention as well. So the way to reduce that is we have a balloon tip guide catheter that's specifically meant for this purpose. So what you do is, if you use the balloon tip guide catheter, you place it in the internal carotid artery, and when you're going to pull your stent retriever and the aspiration catheter out, you inflate that balloon, so you stop the forward flow, and you apply aspiration on the guide catheter. So you're not only stopping the forward flow, but you're actually aspirating and reversing the flow as well. And during that, you pull your stent retriever and the catheter out, so there is no forward force that is going to cause that thrombus to embolize. So it really reduces the chances of distal embolization, but still it can happen. And if it happens, then we've got stent retrievers of smaller caliper. We've got aspiration catheters of smaller size that can go way ahead into the circulation, and you can bring that clot out as well. If you don't have those devices available, then what we do is we go ahead with the microcatheter into that circulation where that clot has dislodged, and we give a small bolus dose of intraarterial TPA, alteplase, and that works on that.
Excuse me.
So, in the interest of time, I think we'll have to skip some questions. I apologize for that. I'm going to invite Dr. Salman Abdul Qayyum, our neurologist from Rawalpindi Institute of Cardiology, to give his presentation and experience of setting up a stroke center in a cardiac center. So everybody asks this question about Rawalpindi Institute of Cardiology doing interventions without a neurologist. So that's not true. We have a neurologist, he has his own team. We have our neurosurgical backup MOU signed with DHQ. We've got Dr. Lubna Miraj sitting here from Department of Medicine, and she's running the stroke wards in our neighboring hospital, and we have a collaboration with them as well. So Salman, we are running short of time, so we need to rush. Unfortunately, we are already late.
Thank you very much, sir. I will be try to
पहले
be quick.
डिस्कशन में टाइम पर ज़्यादा
Can I have my slides, please?
पता नहीं क्या हुआ हो सकता है टाइमर का इशू होगा चलाया No, I know.
Okay, Bismillah Rahman Rahim. So I've given the introduction. I'm Dr. Salman, stroke neurologist, acute stroke program, Rawalpindi Institute of Cardiology. I'll be talking about the experience of setting up stroke intervention service in a cardiac center. So briefly, I would like to share this study that it was published in 2016, that quality of life after stroke in Pakistan, and I want to share two findings here. That in this study, they found that more than 54% patients with stroke were living with moderate to severe disability, and secondly, more than 57% caregivers either left their job or modified working hours due to giving care to the stroke patient. Secondly, the data available about the disability prevalence in Pakistan is not reliable. In contrary to the WHO data, which says that 15% of population may have some kind of disability, but in Pakistani data, we can see that it was in 1998 it was 2.54, and then in 2017 census shows that it has decreased, the disability is decreased. So this is underreported. This is not reliable. I want to share the data of World Stroke Organization. What they say, according to World Stroke Organization latest fact book, the incidence and prevalence of stroke has increased over the last few years. So with all these problems in mind, to start this program, we had initially a visionary leadership and motivated team, ongoing 24/7 primary PCI service, cath labs including biplane, CT scan and 3 Tesla MRI, cardiologists with training in stroke intervention and stroke neurologist. And after 4 years almost, now the thing which we have achieved are, we have developed emergency stroke code team. We have established official WhatsApp group of RIC for conducting telestroke codes by neurologists, radiologists and stroke interventionists. We have trained 4 independent stroke interventionists and training 7 more. We have established stroke HDU and we have trained 3 stroke physicians, and we have established stroke clinic. And we do repeatedly training programs for physician and nurses of our hospital. This is the view of our WhatsApp group which we use for the telestroke advice about the stroke codes. Secondly, there are certain units which are collaborating with us for this stroke care. Important out of these are neurosurgery unit of district headquarter hospital Rawalpindi for neurosurgery cover. Medical unit and medical ICU cover is given by Benazir Bhutto Hospital Rawalpindi, and rehabilitation service center with multidisciplinary team, that is National Institute of Rehabilitation Medicine. They are supporting us in this program. Time is brain, as we know. I will quickly go through this algorithm which we follow in all the patients which come to RIC. And the important thing is the timeline. The first time target is door to CT time, which is 20 minutes. During the workup, initial workup, then CT scan is done in the ER. Then the second time target is door to needle time, that is 60 minutes for the cases which are selected for thrombolysis. And during this time, CT angiogram is done for evaluation of large vessel occlusion. And after that, the third time target is door to groin puncture time, that is 90 minutes for the cases which are large vessel occlusion and they are candidates for thrombectomy. And the criteria we are following, we are American Heart Association and European Stroke Organization guidelines. We are strictly following them to screen the patients and select the patient for the intervention. So we do audit all these timings daily, and this is a view of our daily audit report, in which we discuss our problems and then we try to improve them. Now finally, I want to share the data of which we have collected and what we have done in the last 4 years. The first stroke intervention was done on 13th April 2018, and up till now we have coded more than 5,000 patients in RIC. And this is the yearly distribution. Initially, 2019 and 20, the service was for 6 hours, and in 2021 it was extended to 24/7 service. And you can see the increase in the number of the patients which are coming to RIC with suspected stroke, with the symptoms of the stroke. Out of these 5,000 patients, 14% patients have hemorrhagic stroke and they are referred to neurosurgery unit. 13% have stroke mimic and they are referred to medical unit for further care. And 73% have ischemic strokes. They are further evaluated, which include CT angiogram. Ischemic strokes, the patient with ischemic stroke, out of these, 16% had minor strokes, and after initial evaluation, they are referred to OPD clinic, stroke clinic, and are managed there for secondary prevention of the stroke and the rehab, related rehab. 8% patients were, 8% patient out of this group qualified for stroke intervention, and their intervention were done in RIC. And 76% patient of ischemic stroke, they presented late. Out of these, some could be candidate for the stroke intervention, but due to lack of awareness, they presented late to the hospital. Up till now, we have done more than 302 cases. Last night, one case was added into that. And for acute stroke interventions were done in 302 cases. IV TPA alone was given in 114 patient, means these were small vessel occlusions and they were candidates for thrombolysis. And mechanical thrombectomy was done in 188 patients. They said there is further breakdown of this mechanical thrombectomy. In 142 cases, only mechanical thrombectomy was done, and in 46 cases, initially IV TPA was given and then mechanical thrombectomy was done. And mechanical thrombectomy success rate was that in more than 70% cases, TICI-3 score was achieved. Distribution of vascular occlusion, 64% patient had middle cerebral artery occlusion, 22% had tandem occlusions, mostly with ICA involvement, and 14% has basilar artery occlusion. Now the outcome. Regarding the outcome, we can compare the outcome with the randomized endovascular trials, which show that functional independence at 90 days is between 33% to 71%, which depends upon the selection criteria of that trial. And I want to share here another study that stroke patients treated, that it was published in 2022, treated by thrombectomy in real life differ from cohorts of the clinical trial. It was a prospective observational study, and they found that independent outcome, that was MRS of 0 to 2, was achieved in 26% cases only. So in our data, the good outcome, the recovery, which is written recovery here, was in 42% patient with 26% patient with 0 to 1 MRS within 90 days, and 16% patient with MRS of 2 to 3. 2% patient with who received IV TPA had symptomatic intracranial bleed, and again 2% patient who undergone this procedure, a mechanical thrombectomy, had symptomatic intracranial bleed, which includes reperfusion hemorrhage. We will keep the service up. Stroke intervention is a ray of hope in reducing post-stroke disability in our region. Our stroke registry data will help in discovering status of stroke-affected population. Nationally speaking, more centers should step forward and develop stroke programs to benefit local patients. Our plans under progress, making RIC a state-of-the-art acute stroke intervention and training center. We are getting ultra-fast whole brain CT perfusion scanner with artificial intelligence image analysis software to improve our patient selection for the intervention, and training programs for other centers which are in process of developing stroke program. Well, thank you very much.
Thank you, Dr. Salman, for staying on time. So if you, yeah, sure, go ahead. In the meantime, I'll just invite our last speaker, Dr. Abdul Salam from Taba Heart Institute, to give his presentation. Sir, please.
TPA only. The patients where you gave just TPA, intravenous TPA, what was the result? Recovery
So there was a further breakdown of this. The results with IVT were comparable to the studies. Like more than 40% had MRS 0 to 1 within 90 days. So they were comparable to the other international studies.
Assalamu alaikum everybody, I'm Dr. Abdul Salam, an interventional fellow from Tabba Heart Institute. And I'll be presenting my case, which is a case of mechanical thrombectomy of acute MCA occlusion. This is just a random case of what we have done over the last 2 years. So I'll start with Bismillah ar-Rahman ar-Rahim. So my case is of a 72 years gentleman who is known case of diabetes and hypertension, CKD with baseline creatinine of 2, chain smoker and COPD. He had CABG in 2008 and PCI in 2019 to diaphanous venous graft, and his recent EF was 45%. Presented to our ER with episode of dizziness and vertigo, and he had, just before he come to the ER, chest discomfort associated with mild shortness of breath. So he was tachycardic, and the ECG has shown atrial fibrillation with RVR, which was being diagnosed for the first time, as we have his previous record, and it has shown always a sinus rhythm. So on the further workup, his troponin was elevated, and he was admitted in the hospital for further management. So the next morning, and in the cardiology step-down unit only, the patient has complained of shortness of breath, and when the team came to assess him and examine him, they have noticed that he was not following commands, he was not moving the left side limbs, he had no verbal response, and he was localizing pain only, and that's too from the left upper limb. So his blood pressure was elevated, his heart rate was controlled, and his oxygen saturation was normal in the room air. And on the neurological examination, the right upper and lower limb had power of 1/5 only. His blood sugar was not low, it was 200 milligram per deciliter. So the team immediately have stopped his heparin infusion, and our stroke intervention team, including the neurologist, the radiologist, and the interventional cardiology team, all were involved and brought on board. So his NIH SSS was calculated and came to be 26, considering that his pre-modified ranking score was 1. So he was shifted to the radiology department for an emergent CT scan. So if we see the CT scan on the right hemisphere, it might not be clear over here, but there was a diffuse hypodensity at the MCA territory, and there is loss of the differentiation between the white and the gray matter, which is suggestive of an acute infarction of the middle cerebral artery. So subsequently, immediately, a CT angio was done, and we can see, I think, over here in the view, that the first part of the MCA, which is M1, is intact, showing normal ossification with the contrast, and once we go to the M2, so there is an occlusion, and there is a complete cutoff. Over here, we see the same finding on the axial view, so the M1 is fine. Once it comes to M2, there is a complete cutoff, and this arterial tree, which we see in the middle, showing the same finding. So we have shifted the patient directly to the cath lab, and on the cath lab table, and under ultrasound guidance, and access to the right femoral artery was taken, and an 8 French sheath was placed. And we see the angiogram of the femoral artery, and this we do routinely in our cath lab. So we started from the right cerebral circulation, which has shown no abnormalities, and the left carotid artery, we have seen over here that it has shown no obstructive disease. This all we have seen already on the CTA. So coming to the cerebral angiogram of the left side, so as we see, M1 is fine. At the level of M2, slightly distally, there is a complete cutoff, and this finding is consistent on what we have seen on the CTA. So just to mention that the access to the left internal carotid artery was obtained initially with JR46 French, which was subsequently exchanged on an Amplatzer superstiff wire with a cello guide catheter 8 French, which has a balloon tip. Okay, so inside the cello, we have taken the Navian support catheter that was our intermediate catheter, and it was advanced up to level of the M1, and the lesion of the M2 was crossed with the Sion catheter after taking a microcatheter, which was a rebar microcatheter. So then the wire was taken back, and through the microcatheter, we have taken a solitaire to stent reaver through the microcatheter all the way to the M2, and it was deployed over there at the site of the occlusion. Then the microcatheter was removed, and we have the stent over there. And as per protocol, so the proximal port of both the cello catheter and the intermediate catheter were attached to 50 cc syringe, and continuous negative pressure and suction was done for a total of 5 minutes. So after 5 minutes, the whole assembly of the stent and the intermediate catheter were removed back in the guiding catheter, and they were taken out, and we have succeeded to retrieve a large thrombus which came out with the stent. So after making sure that we have bled back sufficiently from the guiding catheter, we have repeated the cerebral angiogram of the left cerebral circulation, and as you see over here, by the grace of Allah, we have achieved a complete restoration of the blood flow in the whole MCA and its branches. We deflated the tip balloon of the guiding catheter, and the catheter was taken out. We have removed the 8th French sheath, and in this case particularly, we have closed the artery with Brog-Lightberg close, but this is something we don't do routinely, and we have called it a successful stroke intervention. With this, I thank you very much for your attention, and the case is for the panel for discussion. Thank you.
So thank you very much, and with that, we come to the end of this session. I thank all the panelists and would request the next panelist to come up on the stage for the next session. And Jana Ashur sir, just to, in 1 minute, I'll reply to your question. So we all know that with TPA effectiveness is mainly for the small vessels. It's not for the large vessels. So if you have an internal carotid artery occluded and you give TPA, the effectiveness is only 2 to 4%. But as you go distal and into the very smaller branches, that's where the TPA is actually very effective. So if you have a large vessel occlusion and the patient qualifies for mechanical thrombectomy and for TPA as well, then you need to give TPA and do the mechanical thrombectomy as well. You combine the two. But for large vessel occlusion, if you give TPA alone, effectiveness is 2 to 4% for a carotid occlusion. Thank you very much.